Okay, we're gonna live now.
Ok. Bueno, muy buenos días a todos. Sean bienvenidos a la clausura del Congreso Mundial de Neurocirugía, organizado por la Walter E. Dandy Society en conjunto con la UNESCO y nosotros como Asociación SAIN México. Yo soy el médico pasante de Servicio Social Diego Alberto Sonova López. Soy miembro de la Comisión de Investigación de SAIN Chapter México. En la sesión del día de hoy estoy honrado de presentar al doctor Jimmyu Chuang. Él es médico adscrito al Departamento de Neurocirugía en el Chang-Gung Memorial Hospital en Taiwán. Él tiene publicaciones tanto en tumores de fosa posterior, ependimomas, tumores de médula espinal en pacientes pediátricos y neurofocomatosis, solamente por mencionar algunos. Y el día de hoy vamos a empezar con el tema de Resection, Stimulation and Surgical Management of Gliomas.
Good morning, welcome to the closing young people of the World Congress of Neurosurgery, UNESCO Walter E. Dandy Society, in honor of Professor Gazi Gisardil. My name is Alejandro Arias. On behalf of the Walter E. Dandy Student Chapter, we thank the Ambassador of UNESCO Espinet, Jorge Ramos, Chairman of the World Congress of Organization of this event, as well as Co-Chairman Professor Salim Abdulrauf, Chief Abdulrauf of Institute of Neurosurgery, Founding Chairman Department of Neurological Surgery, St. Louis University, St. Louis, Missouri, Global President Walter E. Dandy Neurosurgical Society, and 17th President Society for Brain Mapping and Therapeutics. Also, we want to thank Dr. Deyanira Capi Casillas, President of the Student Chapter AANS IPN, Vice Chairman of the World Congress of Neurosurgery, and Dr. Beyvav Katev, President of the Society for Brain Mapping Therapeutics, Brain Mapping Foundation, and Vice Chairman of World Congress. It's an honor for us to participate in this event, and thank you, Dr. Jimmyu Chuang, for being here today with us.
Good day, everyone, and my dear friends in the world who are fighting with neurological disease and COVID-19. My name is Jimmyu Chuang. I'm now in Taiwan in the evening around 8 p.m. It would be a great honor for me to make a presentation at the closing of the World Congress of Neurosurgery. I was specialized in signal processing and functional network and seizure network mapping, but today is surgeon talk. I would like to have a short sharing about my personal journey to learn how to surgery with the glioma with integrated approach with functional image and electrostimulation mapping and microsurgical technique for glioma in eloquent cortex. Let me introduce myself briefly. I work in Kaohsiung Chang'an Memorial Hospital, a near 3,000 beds medical center. Clinically, I was specialized in brain tumor surgery, skull-based surgery, and pediatric. I did my research with neurosignal and neuroimage processing. I did long-term fellowship training for more than 3 years after recent program, majoring in Memphis with Professor Rick Booth. I also spent time in Little Rock with Professor Ali Christ, Oriental with Summer Albarber, and Istanbul with Professor Touré. This talk is dedicated to all of my mentors, to their kind and warm mentoring. No words can express my gratitude. And also, this Congress is present in honor to Professor Yasachu. He is the mentor of mentors, master of masters. I stayed with him in Istanbul in September 2017 when I did fellowship with Dr. Pire. It was a very good time. I miss the professor. Today, I will have a short sharing about my topic, integrated approach with functional image, electrostimulation mapping, and microsurgical technique for gliomas in eloquent cortex. First, introduction of glioma surgery. We all know glioma, especially malignant glioma, is characterized by its invasive and infiltration nature. Surgical resection is unlikely to be curative. The standard therapy for newly diagnosed glioma involves surgery plus radiosurgery plus adjuvant temozolomide or warfar's Guido. However, most of the patients still face tumor recurrence and poor survival. The reliable prognostic factors among the many tumors and treatment-related parameters, only patient age, tumor histology, performance status, and some molecular markers have been identified. Increasing evidence supports that the extent of glioblastoma resection independently correlate to overall survival. So it was believed that patients who undergo maximal resection probably have a modest survival advantage. Due to the frequent location in eloquent area and evidence of the risk for disease progression and poor survival when tumor involving eloquent location. The aim of the modern surgery policy is to maximize the quality of resection and to minimize the risk of surgical sequelae. The resection of the glioblastoma located within or adjuvant to the eloquent cortex or subcortical pathway remain a challenge to surgery. Advances such as neuroeducation, functional image, intraoperative functional MRI, fluorescence guide surgery, laser surgery, and intraoperative electrostimulation mapping have improved the safety of surgery and increased the extent of resection that can be achieved. There are three major different philosophies of the glioma surgery. That is, first, imaging guide resection, stimulation guide resection, and the microneural anatomy guide resection. When I was a resident, most of my senior college did glioma surgery with image guide resection and maybe part of the microneural anatomy guide resection, but not the real one. In 2010, when I was the 5th year of the neurosurgery resident, I got my first toy, an intraoperative monitoring and mapping machine. And I started to follow the giant. Let me introduce my initial mentor in spirit. This is Hugh Stufall, Mitch Berger, and George Ogerman. So I did the first motor mapping surgery in Southern Taiwan in 2012, and first awake surgery in 2016. And I became the follower of the stimulation guide resection since 2012. So let me present a very old case. Initial I treated of the motor eloquent GBM that I operate in 2015 or 16. You can see the whole mapping practice before and during the surgery. This is a 41 years old female, and progressive left hemisphere was found initially. In brain CT, you can see the lesion just occurred by adjuvant and motor eloquent area. Obvious perilesion of 5-meter edema, midnight shift, and heterogeneous enhancement, and high intensity of DWI sequence. And this is MR spectrogram, malignant appearance with decrease of NAA with calling ratio and increase of lactate peak. This is calling map. I usually do calling map and try to identify the most malignant region, which I will send a pathology specimen during surgery. And this is our motor functional MRI with hand. And the impression before surgery is right side high parietal eloquent region brain tumor favoring high-grade glioma. And we do some pre-surgical functional workup, including functional MRI, functional image, transcranial magnetic stimulation mapping, and intraoperative stimulation with electrodes. We do transcranial MVP mapping and try to locate the maximum response and markers them. And this is our 3D DICOM image post-production. This is our bulk signal analysis with hand. This is a hand functional MRI and feed functional with yellow color and generate from functional area for cortical spinal tract. And MRI generate 5-meter tractogram. This is hand-associated cortical spinal tract. This is 3D reconstruction and wound planning. And this is 3D reconstruction of the topographical cerebral surface rendering for pre-surgical planning using the software Orthorix. And this is our intraoperative monitoring planning. So we try to do MEP and cortical subcortical stimulating and SSAP for phase reversal during surgery. So we got prepared and the navigation system with functional image and spatial anesthesia protocol for mapping. And we check the control side for transcranial MEP stimulation, make sure that the channel is correct. And when we open the dura, previous surface rendering will help not to trust your navigation alone. It's the golden world. And we set the non-eloquent area first. and SSP phase reversal for central sulcus mapping. And this is the Elecrtrical side. We will resect under cortical and subcortical stimulation. And this is cortical stimulation. And resection with subcortical stimulation, we use push and draw technique to detect cortical spinal tract. Resection until 5 milliampere stimulation got response. I usually did bipolar stimulation with low frequency on cortical stimulation and monopolar stimulation with high frequency on subcortical stimulation. In this patient, she got immediate motor improvement after surgery. The resection margins are almost parallel to the choroidal spinal tract. The distance around the surgical margin and the cortical spinal tract is around 5 millimeters. The pathology is GBM. She got very good functional outcome in this surgery. And you can see I did not only perform intraoperative mapping alone, I did functional image and transcranial magnetic stimulation before surgery. So what is the contribution of the intraoperative electrostimulation mapping with functional outcome and survival analysis? Recent literature revealed a positive impact with usage of intraoperative electrostimulation mapping during tumor surgery in eloquent area. However, controversy still remains. The usefulness of the intraoperative mapping has not been addressed in randomized trial and seems to be impossible to be achieved. Reason why? The first of the reason is due to multiple modality of the advanced tool for tumor resection. It is difficult to assess the exact role of the SOAR electrostimulation mapping. Second, different institutions usually have different surgical strategy and surgical equipment. Third, the tumor's histology have not been all be the same, and the location of the tumor is hard to be uniform in one study. There are two comparative studies in the literature operate on with and without intraoperative simulation mapping for brain tumor in a single institution. Resection and the colleague series include from low-grade to high-grade glioma and even metastasis and meningioma. Duval has a landmark article, but focus on supratentorial low-grade glioma, but multiple locations of these tumors. To minimize bias above, our study is a unique comparative study in a single institution to compare the possible contribution of the intraoperative electrical stimulation mapping. For glioblastoma resection, focus on within and adjuvant to the descending motor pathway. We include an uniform consecutive sample focus to try to evaluate the contribution of the electrooperative electrostimulation mapping on resection quality, functional outcome, and survival prognosis. A total of 70 patients were included in the present study. During January 2008 to December 2015, a total 11 surgery participants with 50 patients conventional resection without mapping. We start intraoperative electrostimulation mapping and monitoring for brain tumor in December 2013. And between 2014 to 2015, there are 13 patients underwent resection surgery with mapping by 3 surgeons. One is mine. Clinical characteristics and the image finding are shown in table. There are no difference between 2 groups with gender, age, tumor volume, pre-OP neurological status, and Cat67 index. A permanent major neurological deficit ratio in mapping group are shown lower, and the neurological outcome in the mapping group are better. Post-op immediate additional neurological deficit ratio was 3 times less in mapping group. But both post-operative immediate additional neurological deficit and permanent neurological deficit did not reach statistical significance in 2 groups. Gross total resection or near total resection were achieved significantly higher in mapping group. External resection was also significantly higher in mapping group. With a mapping and non-mapping comparison with survival analysis, program-free median survival time was significantly longer among patients with mapping group, with significant significance. But median overall survival were longer, but not reached to statistical significance. So what is the contribution of the intraoperative electrical simulation mapping with functional outcome and survival analysis? You can see I'm not only perform the intraoperative electrical mapping. I did functional image before surgery. So there's no difference between two groups with gender, age, tumor volume, and pre-OP neurological status. But you can see, but both sides of patient are doing mapping, but the patient doing mapping and with pre-surgical functional image have better cortical stimulation response rate and subcortical stimulation rate. And also, they have better resection quality. Although this is not reached to statistical significance. And within functional image mapping group and non-functional image mapping group, the survival and the progression-free survival analysis, you can see that the progression-free survival group, that the patient with functional image are better. But also median overall survival rate did not reach statistical significance. So there's a controversy that many people do not believe the image guide resection. And to my idea that image guide stimulation are very guaranteed. When we talk about the track, like something like tractogram or functional MRI produced by the box signal, actually they are not definite true location or the true volume where you make from the software, but you can doing the intraoperative stimulation to locate it, and this is a very core idea. Many people do not believe that the functional image, but if you can do simulation based on your functional image, and it increase your stimulation rate and even increase your resection quality. Since 2016, I spent 2 years in America, and the major part is Memphis with Professor Rick Boop. When I first observed Dr. Boop's surgery, everything different from me. He did lesionectomy every time without any mapping and even without navigation. I finally realized Dr. Boop is not a single neurosurgeon alone. Behind him, he's part of a small group they call Little Rock Empire. This is something just like Mystery Rich in the Middle Age. Their godfather is Professor Yasacher. During these 2 years, I spent another more 3 months in Little Rock with Professor Ali Christ, 1 month in Oriental with Samer Arbaber, and 1 month in Istanbul with Professor Ture and Professor Yasacher. This is Yasacher and me again. This is the philosophy of the microneural anatomy guide resection they taught me. When we call lesionectomy, there is a key word called microvasculature based on embryology thought. It becomes a guide for glioma resection boundary. So my thinking process has something changed during this 2 years fellowship. So back to our patient. I operate her before going to America for my fellowship. And during my 2 years fellowship, I keep growing just like her tumor after Tramadol and Avastin treatment. So when I came back, it's the time to do second resection for recurrence. Everything almost the same. I do functional MI, and I do pre-OP image simulation, and this is the 5 tractogram. Okay, all the same and the same one. Similar location of the brain tumor, and similar intraoperative monitor and mapping guide. Same one. This is the second time surgery when I opened dura. Okay, the only difference is my surgical thinking process. I did lesionectomy this time. I believe I reached to very close to corticospinal tract. I still use cortical stimulation for checking, but not guidance. And the final stimulation protocol is to 2 milliampere. This is the most minimal the electrical stimulation that I have to perform. And I put wafer at the end of the surgery. Post-op, the CTs look very clean. And post-op MI almost reached to gross total resection. We usually do not say gross total resection in GBM surgery. But Immediate additional hemiparesis was not after surgery, but she recovered fast. She can work with worker after 1 month of the surgery, but she still pays something. It is worth. We can see post-op image. The first time surgery, the stimulation guide resection is reached to near total resection, and the distance from surgical margin to the cortical spinal tract is around 5 millimeters. And the second surgery, I do microneurosurgical resection, just we say lesionectomy, and almost gross total resection. But patient got a little bit hemiparesis. Today, I will show you my recent case and show you my recent advance for integrated multidisciplinary approach with image stimulation before surgery and mapping in the surgery. This is a 79-year-old man with chest complaint of language and cognitive impairment. He also has minimal right side hemiparesis. Brain CT show left side temporal intraaxial tumor with brainstem compression. And anatomical MRI shows that lesion just occupy left side superior temporal region with strong heterogeneous enhancement. This is the lower part, and this is the upper part. And T2 showing the perilesional edema and high signal of the DWR sequence. And we also do functional MRI with motor function. This is on the SPM 12 of software in MedLab platform. This is motor function of the right leg. And we also do language function and calculation function. So you can see this is our flow chart or the protocol of the neural image 3D reconstruction. And every image sequence are tricked to create proper anatomy object to fusion in the software platform. In this slide, you can see the platform is BrainLab. And we did a 3D reconstruction image simulation for surgery. Okay, we show, you can see this is the patient, the head that we construct from CT, and we turn it from back row, and we turn it from upside view. And this is the tumor that made from T1 contrast MI. This is thalamus. This is brainstem. This is ventricle. They are all object creation, but by the MRI different sequence. And this is MCA vessels. And you can see the tumor encased the vessel. This is the bone. This is the cortex. And now you can see the green part is the right feet functional MRI zone. And the blue part is right side hand functional MRI zone. And then we turn to backward view and generate tractogram from our functional MRI zone. This is our feet cortical spinal tract and right side hand functional MRI zone. And this is our right hand cortical spinal tract. And we turn to the lateral view. This is cortex. And you can see the C-shaped fiber fascicle. This is accurate fasciculate. It's something like language fiber. It's just cover the temporal lobe, brain cortex, and just laying on the tumor. So you can see when we see the anterior view, you can see that the lateral part of the brain are very functioning. The yellow part is the M1 perforation area. I usually locate it and leave them alone. Try not to interval this part, this perforation zone. And we turn back to the lateral side. Backward, upward. This is the visual fiber. And this is the tumor associated fiber. And then we try to decide the best corridor for the surgeon view. Usually I make decision about my head position. And I will decide my craniotomy planning and my wound planning at this time. In addition to the simulation, I also working with the inside of dedicated part around the tumor. You can see this is below this plan, there will be the MCA perforator, not here, but below this. And you can see the lateral and posterior part of the fiber of the tumor are language pathway. So it's very sensitive. You cannot traction the lateral side of temporal lobe. And the part that the medial posterior part is the descending fiber that is corticospinal tract. It's a motor pathway. You can see the tumor just push away, but not invaded to the pathway. This is very important before the surgery. And on the medial side, anterior part of the tumor, there's hippocampus and optic pathway. So I make my stimulation. First, I will do stage 1 from the tumor lateral side, just separate from the temporal lobe. And you have this part is very sensitive, so you have to not to traction the covering temporal lobe. You have to very gentle. This part you cannot do monitoring. If the patient is younger, I will do awake surgery. But this patient is too old and his cognitive function is not good enough. So I do not do awake surgery for this patient. And you can see his language pathway are just covered on the lateral side of the tumor. And when you reach to the bottom of the tumor, how do you know you are close to the motor pathway, the corticospinal tract? Easy. Use motor electrical stimulation mapping. So I use mapping, try to identify the bottom margin of my resection. In our functional MRI and MRI sequence, you can see the corticospinal tract was pulled away but not invaded by the tumor. This made me confident that I can preserve the motor function after close to the resection. And the stage 3 are try to separate the median anterior part of the optic pathway and hippocampus. In the image, you can see the tumor is already invaded to the visual pathway. So I know it's very difficult to preserve the visual deficit. And actually the patient have already had visual field deficit before surgery, but we still can monitor it and preserve the residual function. And I will use the visual evoked potential monitor with the grid. And the final, I will try to left minimal tumor on the perforator zone and not to reach them. In this part, I will do MEP monitoring. So you can see, I use the functional image, anatomy image, try to do the simulation and keep caution to every part of the danger area. And this is a real surgery. This is the one and maybe the tumor. And I do the monitor prepare. In VEP, visual evoked potential, we have the LCD eyeglass that put on the eyeball, and it will flash and the recording on the visual cortex just on the posterior of the scalp. And also I do motor evoked potential. And bits of the EEG monitoring are usually used by my analogist. So the first part, I do the lateral part of the tumor. And when I reach to the bottom of the tumor, I use stimulation, try to locate my motor pathway. And on the stage 3, I try to separate the anterior medial part of the tumor with the visual fiber. I use visual evoked potential with my grid. And finally, I left some tumor on the perforation zone. This is the final photo. After the surgery, the patient have minimal additional motor aphasia, but recovery almost in 2 weeks later. This is post-op CT, very clean, and post-op MRI, the resection rate is reached to 95% and or more. The pathology are GBM, and it's IDH1 mutant type. So this is the one. Okay, so you see what is my choice from the different surgical philosophy. This is my journey that going around this philosophy. So what is my final choice? And the real question is, what is the balance? This is choice, the different philosophy. I do not have a final answer, but I did have some thinking. In my presentation of the patient, although in the first patient presentation, although she improved after surgery, but not total recovery, is it worth? Did she have benefit for survival? So what is the balance between quality and the resection quality and the life quality, especially in survival analysis? To minimize the bias about in the single our institution, I try to evaluate. You can see if the patient reached to 90% resection, they got better free survival. It had great impact both in progression-free survival and overall survival. But if you check survival impact with different functional outcome, it makes big difference. You can see if the patient have major neurological deficit, then the survival are harmed. Even we use post-OP immediate motor status for parameter, you can see the curve are still separate. So we separate the patient with the good motor outcome, stable, and resection that combine with. You can see if you reach 90% resection and good positive motor outcome, that's the great survival curve. But if you not reach good quality resection, but still good motor function, compared to not reach to 90% resection, but poor motor or decreased motor function, the survival are similar. So right now, I do have some answer, but this is my current conclusion. I will do image guide stimulation to keep good stimulation quality. I believe it will also improve resection quality. And I do become very careful to keep the balance between resection quality and life quality. And right now, I show you the integrate multidisciplinary approach with 3 combined. One is functional image, one is electrostimulation mapping, and one is the microsurgical technique scale. So there is a very important take-home message. First, post-op neurological deficit do harm to survival. This is very important. And second, the integrated multidisciplinary approach with functional image, electrostimulation mapping, and microsurgical technique do help for glioma in electron cortex. Thank you very much.
Thank you so much for this amazing lecture, Doctor. We would like to go to a question and answer session. Uh, Diego, would you like to say to ask a question?
Yes, thank you for the presentation and the insights for the topic, Dr. Mingyu. We have a question about the utility of the markers KI67 and KPS as
Yes.
prognostic factors for gliomas. Are these prognostic factors being used nowadays? And could they assign risk for mortality or recurrence? What do you think in this regard?
Because our molecular marker are not uniform, so I'm not present the data in this presentation. We have very complete molecular markers since 2018 after coming back from US. So right now we routinely do something like the IDH1, IDH2, MGMT, something like that. But before 2015, most of them, we do not do every marker in those glioma surgery. So that's why I picked Cat67. But I know the Cat67 actually do not correlate to the final survival, I think.
Okay, thank you very much, Doctor.
Thank you so much, Doctor. Another question would be, there are nowadays certain theories that says that actual tumor extension is greater than that's shown in images. How does this impact in the outcome of surgery and the free survival time? Is this a factor to take into account apart from those that you described?
I'm sorry, I did not catch the first sentence.
That there are certain theories that says that actual tumor extension is greater than those that extension shown in images, and if there are like if this does impact in the final outcome of the surgery.
You say the image? Um, I'm sorry, I did not catch the key word. What impact of the survival? You mean the functional image? Sorry.
Sorry, that may be a problem with the audio. No, what I was asking was if or there's this theory that says that uh, the tumor, the actual tumor extension, may be
Actual
great.
tour retention?
The tumor may be greater
Oh,
than that's shown in the MRI
yes.
because of infiltrating cells, and I don't know, this kind of an interesting theory. I don't know if this has an impact on surgery on survival.
Oh, okay. I have to mention that not all the image are real. That some image are you can trust it, but some image you can't. So something image that you cannot trust, you have to find another way to make them more confidence. And to our study, every functional image that we can locate it during the surgical mapping. Is that what you ask?
Yes, thank you, doctor. Well, I guess we don't have like another question. Do you have another one, Diego?
No, I think that's all the questions. Thank you very much, doctor.
Thank you both. Thank you very much.
Muchísimas gracias por estar acompañándonos en esta sesión del tercer día del Congreso de Neurocirugía. Los invitamos a mantenerse pendientes de nuestras redes sociales. Vamos a tener todavía un par de conferencias más el día de hoy. Y pues agradecerles muchísimo de nueva cuenta al comité organizador, encabezado por el doctor Jorge Herrera Ramos y el doctor Salim Abdulrof de la Sociedad Neurológica Walter Dandy. Muchas gracias a todos.